Good afternoon, everyone. Thanks for coming back after lunch. It's lovely to have you here. I'm very grateful to all of you who couldn't get into the communication session and chose to come here instead. It's allocated to you. We hope that you'll get something out of today anyway. The idea is this is so the session is about resilience, and the title is, and the focus today is really that resilience is not about you, it's not about your personal resilience, it's about a system. So first of all, if you are here for personal resilience and you brought your yoga mat and you're expecting exercise and stretches, I'm afraid this is not the place. When we're talking about resilience, I'm just going to start off with a definition so people know what we're talking about here. So resilience is the ability of the team or system to monitor and adjust performance to achieve our goals. Okay, so this is not about us being robust or our personal resilience or anything like this. What we're talking about here is about the ability of systems to recognise opportunities and risks and respond to them flexibly. Okay? Now before I go on, I'm going to introduce the faculty. Some of you may have already heard Fiona Miles, who is one of the intensivists at PICU, who's helping out. We have Mark Edwards, who's the Director of Quality and Safety for ADHB, and Jane Torrey, who is the Director of the Simulation Centre for Safety, Patient Safety in Tamaki, and also an anaesthetist at Auckland Hospital. I'm very grateful to them for helping out. So the objectives of today are really about trying to get you guys to understand about a new model of safety. So we're all here because we want care to be safer and patients to be safer and staff to be safer. And so today the objectives are really talking about a new model of safety called Safety 2, understanding about what makes systems resilient as in able to adapt and monitor, and understanding a bit about adaptive teams. And we've talked quite a lot about teams and response teams and things today already, but we're just going to give it a slightly different slant on things. I'm sorry for all those, because of the table structure, you've now all got to turn around and you will be doing yoga by the looks of it. An outline for the day, this is we're going to talk about an introduction, so a brief chat about this. For those of you who've been to my talks before, I apologise, there's some stuff the same, but there's definitely some stuff that's new in there. We're going to talk about the building blocks of a resilient system, and that is the potential to respond, so talking about adaptive teams, the ability to monitor and looking at the gap in our expectation of where we are and where we thought we'd be, the ability to anticipate, seeing into the future, and the ability to learn about making sure we're fixing the right problems when we do have incidents or when we're trying to design better systems. And at the conclusion there'll be hand-holding and singing, and I certainly hope you'll hang around for that. This is a workshop. This is not a lecture for 2 hours, although it was tempting. But this is a workshop. You have the answers. You guys are clinicians and managers and patient advocates and auditors, all people. So the viewpoints that you have are really valuable, and what we want to do is to show you a new way of looking at stuff and then seeing what it means to you and your worlds. So you have the answers. We're going to get you to share the airtime. If we cut you off, it's not because we don't think what you're saying is valuable, it's just we want to make sure we spread the love around. And we will be timing. It's quite a tight program, so we're going to keep things pretty tight. The way it will work is that when we do the workshops, there'll be a 10-minute discussion about some questions we put up, and then a 10-minute report back. And that will probably be 3 minutes for the first group to say what they've got into, and then some other things from each table about other things that they've found or what it means to them. Does that sort of make sense? We probably won't get around every table every time. In fact, we won't. But the discussion's really important. And the key with all this is about what you take from today and take back to your workplace and how it changes the way you approach some of the problems. Is everyone kind of okay with that? Great. Everyone comfortable? No? All right. For those of you who are facing backwards, just turn around for the next 20 minutes. Is that okay? Otherwise, you're going to be wrecking your necks and backs. And I'm just going to give a little chat. Is there anything else, Jane? You can jump in and tell me what I'm missing. All right, good, thumbs up. All right. So we talked quite a lot about the way we work. And the first of all is I wonder, this is your hospital. They snuck a camera into where you work, and it's a factory. And people come in and they get diagnosed and they get treated and they go out and we concentrate on flows, and we're kind of like a factory. And we just bring people in, we do stuff, and they'll get better and they go out. Churn, 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 churn. And if everyone does what they're meant to do, then the system works and it's perfect. That's called work as imagined. And when you talk to families and patients, sometimes they say it's like being in a factory. And when you talk to staff when they're at their worst, they say it feels like I'm in a factory. And so if you have this model of healthcare as a factory, as a linear system where we bring people in, we do stuff to them, they get better and they go out, then that changes the way it affects the way you think about safety. So for all sort of systems where they're based on this idea of sort of factory thinking or mechanistic thinking, and it's not just healthcare, is that for those situations, the aim of safety then is that as few things as possible go wrong. The natural state of the factory floor is that everything works if everyone does what they're meant to do. Okay, you've all heard this sort of, so this is, safety is when things are as low as reasonably possible. Harm is minimised. And this view of safety, this is not from me, this is from the safety scientists who are looking at all this stuff. They talk about this current view of safety, so safety one. And the idea here is that if you imagine if there's normal functioning of a system and everyone follows the rules, does what they're meant to, make sure that they adhere to all 2,213 policies, procedures and guidelines, that we end up with an acceptable outcome. Success. Ta-da, it's good. The only time we need to think about our system really is if something unexpected happens, if there's a transition, if someone doesn't follow the rules, something breaks, there's a problem with the system, and there's malfunctioning of the system and there is a failure. And so we need to look at what were the causes of the failure and go back and find out what was the malfunctioning. So this model says that the causes of success are as it should be, and the causes of failure are malfunctioning or non-compliance. Does that sort of make sense? And if you think about that, what that would mean is that this would be very uninteresting. The top bar would be very uninteresting. We wouldn't really care how that happens. That's just the way the system works. We only need to pay attention if there's a bad outcome. And when we see that, we look back and we try and find what went wrong. The most notable thing that we all sort of know about this, the model that we all hold in our heads, is called the Swiss cheese model, where there's this idea that there are hazards and there's either upstream hazards in the organisational policies or drivers, there's actions or non-actions of people, and there's a failure to sort of rescue or intervene down the line. And this creates these sort of latent errors that line up, these holes in the cheese that line up and create harm at the end of it, or a patient safety harm, something bad happens. And is that kind of the model? Everyone understands the Swiss cheese model? I think it's been really successful as a way of communicating that there are multiple levels of problems, not just the patient, but the organisation. But it has some limits. So part of the problem is when we do this, we start from the end of the Swiss cheese, where the things have lined up, and we start from an incident. And we only pay attention, remember, when we've had an incident. So we start from a known outcome, and we look back. We see the holes, and we see how they lined up, and we find and fix the holes. We fix all those latent errors, those latent holes in the cheese. We make sure that people are being compliant. We bring in new rules, or we make sure that there's training, go and learn the 5 rights, go and learn the 5 moments of hand hygiene, go and read the policies, procedures and guidelines. Here's another checklist we're going to bring in for you. And if you think about, there's been a big flourishing of this approach. We now have checklists. If you think about daily care plans, pressure areas, falls assessments, all these things are essentially checklists. They're all complex socio-technical interventions that are designed to make life easier and safer, but we keep on layering more and more of them in. And we often put in more and more defences. We're going to add a second check to the medication. We're going to add another booklet, another chapter in the booklet to fill in for admissions, or for a surgical admission pack. We're going to bring a whole new pack. We're going to design some more and more forms you have to do, and then when you don't do it, we're going to say, well, you should have done more documentation. We often constrain the system by saying you can only take up medications within 10 minutes of when they're charted. It means suddenly and you then standardise medication times, suddenly means that there's a big queue around your Pyxis or around your pharmacy. So often when we're trying to make the system safer, we focus on trying to constrain it more and more and more. Okay. Is that how it feels? Maybe, they say. Yeah, okay. And in this model, and it's not just in healthcare, people are a liability. If I could just get rid of the bad nurses, this place would be fine. Those doctors, dreadful people. People are a liability, and where we find they're variable, they don't do what they're meant to, and they are the weak part of the system, and where possible, we should standardise and then automate and get people out of the system as much as possible. And that is quite a common approach now, automated calling, trying to remove things from people, that people are the weak part of the system. So safety one, and I hope you recognise this because I think we do see it every day, is that as few things as possible go wrong. It's reactive. We're only interested when something bad has happened. Humans are a liability or a hazard because they don't do what they're meant to. Accidents are caused by failures and malfunctions, and the idea is that we try and find the causes and fix them. We look back and we find those causes and we do it. And this approach has been going now since at least 1999, 2000. So in 18 years' time, we had hoped that we would make a 50% reduction in patient harm events by 5 years. That was the Clinton sort of hope from To Err Is Human. And it has to be said that that has not been realised. The changes that we've made to safety we've seen patchy changes that are often non-sustained or are localised and may not be as reproducible in other areas. And so our progress has not really been what we would hope for. So I guess why isn't it working the way we'd hoped? So let's just go back. We're just going to wind back a few things. And I want you to think about some of these things in terms of some of the discussions that have been going today. When you start from a known outcome, when you start from a plane crash on the ground or a patient harm or a death or whatever it might be, you are immediately biased by the event and by the fact you're looking backwards. Okay? You arrive at the crash scene and you're like, oh my God, this is awful. Something awful has happened here. We must find out what's happened. And so we immediately start and we look back and we find the bits that tell us a story that makes sense. Okay? So before the accident, things don't look very clear. When you look backwards, we cherry pick the bits that make sense based on knowing an outcome. This happened, that clearly meant this because of the outcome. Oh, well, they did this, that makes sense because of the outcome. And one of the most powerful pieces I've read was by a woman called Deb DeBono, who's a nurse who specialises in looking at nursing workarounds. And she wrote a chapter on a whole lot of nursing workarounds and described the nurse's day. And there were all these things they did, like stopping medication to grab the patient before they fell and having to rush and do things and taking 2 drugs to make sure they got them on time and all these things. And at the end of the chapter, she goes home. And you realise she's described a normal day. Whereas normally at the end of that story is, and then the patient died, or then the harm happened. And so these things that we assign cause to are often the things that are going on all the time. And there's reasons why they happen. So after the accident, we see a nice linear story that makes sense, and we can see the holes and it all makes sense. But before the accident, we don't live our lives backwards, we live our lives forward, and we are constantly making decisions about what do I do in this situation, what do I do in this situation, how do I balance these competing priorities? And we are always trying to make the best decision that we can at the time. And the outcome is not clear before it happens. The other thing about this approach is it limits learning about our system. We only look at things that go wrong. We have no interest in why things went amazingly well, and we have absolutely no interest in how usual work happens. So the rule about 10% of people are harmed in healthcare is actually fascinating. When you think of the complexity and the patients and what's going on with them, 90% of people come through unharmed. And we have absolutely no idea how that happens. It's not because they come and they sit there passively and we all follow the rules and it goes on like that. We are constantly working, we're coming across things that we weren't expecting, patients respond differently, they present differently, the conditions present in all sorts of ways, and there's a whole lot of active work that goes into creating it, into creating a good outcome, and it's entirely invisible. We have no idea how that happens, and it's uninteresting to our system. And when you think about it, trying to understand safety, this is from a friend of mine who's a Dutch, she's actually a med student, just starting training, but she's done a PhD in safety. She said, trying to understand safety by looking at instances like trying to understand successful marriage by only looking at divorces. When we try to build a system about safety, we focus on the moments where safety was not present. We look back and we say, well, there clearly that wasn't it, so the opposite of that must be what makes it safe. But we haven't actually paid attention to what were the instances where nothing happened, where things were challenging, but we actually found a way through. That is an active safety. We create brittleness. We hide these sources of adaptability and innovation. The phone call you make to radiology that pushes the patient to the top of the list. The surgeon that you manage to get out of theatre to come and see the case you want. The doctor that you find a way to suddenly get where you need to. The patient family who just say, by the way, I've noticed. So those sources of adaptability are lost, as are the sources of innovation, the things that we do differently that work better. We're not interested in them at all. We often make normal work harder. We introduce more and more barriers to normal work and more checklists and more things we have to do without really thinking about how they impact on us. We're designing looking back at the last scary thing rather than thinking about how do we make the system work now. And we can often introduce new complexities and new ways the system can fail. And I think it changes the way that we see ourselves. If you think about it from what we were saying, health, people are a problem, is that it turns us into passive people. We want to sit there and just follow the rules, do what you're meant to, do your checklists, do your scoring systems, and that's it. That's good care. And we know that's not true. And I think it also affects the way we think about patients. Take your drugs, turn up to clinic, do what you're told, and it'll be fine. Sit there, everything's fine, don't worry your head, it's all okay. Staff are passive, patients are passive. And I think for staff, if you make the link in this, is if we only pay attention to people when things go wrong, and we never pay attention to them when things go well, despite how tricky it was, we're kind of saying it's as it should be, or it's bad. Bad robot. So it's not particularly surprising that we're starting to see a big problem now with burnout and disengagement and people feeling sort of ground down over time. And even when we try and fix these problems, we often try and upgrade the components of the system to people. We say, we're going to send you off, you're going to go and learn how to do the 5 rights, or 20 rights, or something, however much it is. We don't say, why weren't they followable, what was going on? We say, go and learn the 5, 20, whatever, how many rights there are. Go and be educated, go and read the policy. We're going to drill for this. We're going to design a scenario around this exact scenario, a simulation around this exact scenario, and we will make sure that everyone has always seen this particular problem. If you're feeling broken, we're going to send you on a mindfulness course. I do mindfulness, but I'm not hassling, but it's not a solution to a system problem. It's a way of helping, but it's not the answer to why people feel burnt out. And we send people for empathy training. I ask every registrar who comes in why they did healthcare. I like science, I was good at science, and I want to help people. And then we break them and we send them for empathy training. What? So it's not particularly surprising we have a problem with staff burnout and disengagement. The way we work and the way our systems are designed are fundamentally mismatched to the way we actually work. So the fundamental problem, it's really easy. The cheese is alive. We don't work in a factory. We work in possibly the most complex socio-technical system that's ever been, which is healthcare. Modern healthcare is ridiculously complex. There are so many interdependent parts, they're constantly moving, they look different in different situations, and we are constantly trying to find our way to navigate this. And we heard today about how the hospital now is so different to how it was 18, 20 years ago. And we see it. No one comes in with, I'm just having this one problem. I'm having this one problem, but I've got a social thing, and my loans, and my car, and my health. Everyone's got these massive problems and they're constantly dynamic and changing. And so the world we work in is dynamic and uncertain. And actually, the work we do is not like a factory. This is the work is done. This is how we actually do stuff. This is a model of an emergency department of who talks to who to make stuff happen. And it's not the, I come and I get triaged, I get seen, and I go out again. There's a whole lot of work, active work being done. And this because we are constantly making trade-offs. How do we make the system efficient enough that we don't breach our 6-hour rule, that we get the system flowing, that the flow comes through, we get the patients out so we get the patients in? How do we keep the system? Because that's a safety issue too. But how do we make sure we're thorough enough to meet the needs of the patient, to make sure we do the right thing at the time? And we are constantly finding ways to juggle how to make it efficient enough and thorough enough. And that's a way of judging an uncertainty, which is what we have to do all the time. And that's the reason why there's a gap between the work as imagined of policies, procedures and guidelines and the work is done on the floor. It's because it's not that work is done, that what we do is wrong, it's just that it's under-prescribed. Basically, you can't say, in this situation with this patient at this time with this condition, do this. And there's this great thing about people say, well, the rules are there, but use your common sense when they apply. But if something bad happens, we're not going to go back and say, well, you used your common sense, that's okay. We say, why don't you follow the rules? So there's a new view of safety. This is, again, not from healthcare. This is from a guy called Erik Holnagel, who's a professor of safety science in Denmark. And he says, the things that keep the system safe are the performance adjustments, the things we do to keep the system efficient enough and thorough enough. And they're the things that are the root cause, if you want to call it that, which you wouldn't, but they are the reason why we have acceptable outcomes. And under some conditions, when there are excess demands or things are different to how we expect or whatever, they can also be the cause of unacceptable outcomes. But it's not that behaviours are good or bad. It's not that variability and adaptability are good or bad. It's just that, so we are now in the situation where we are the dual creators of safety and of unsafety. Okay, and it depends on the conditions and how well matched we are to what's going on. But there's a really interesting thing that comes from this. The system only succeeds because people and teams are able to adjust to meet the conditions of work. Complexity is the problem. The nature of the work we do. People are the solution because people are able to adjust, to judge changing conditions and make judgments based on how do we achieve the goal. Okay? So actually, people are not your weakness, they are your strength. They are the key resource you need. So the new aim of safety totally turns this around. It says, rather than saying we're going to just get rid of bad things, we say, if the variability we do and the things we do can either lead to good or bad outcomes, how do we make sure but as many things as possible go right? How do we make it most likely that the outcome we want is the outcome that occurs? And in some ways, this now aligns our production ideas about how do we get people through in a really good way with also making sure that we align with making it easy for staff to do those things. So we're making that success more likely. So safety 2. As many things as possible go right. It's proactive. We don't wait for bad things to happen. We are continuously trying to anticipate developments and events. Humans are seen as a resource necessary for system flexibility and resilience, the ability to adapt and respond to things. The purpose of investigations is not to look at what people did wrong, but to understand why people who are doing what they normally do and what normally works for them, why it didn't work this time, what was different about the conditions. And were there things that were going on that meant that the usual situation didn't apply? Does that sort of make sense? It's a totally different mindset. People are a strength. We design it to make success likely. We try and create successful outcomes. We are aligning the business with safety. We don't have this tension between, I know I should do the right thing, but I want to get people through. We are aligning those things together. So that's the theory, and it's very brief. But it's only useful if it actually has some implications. So there is nothing so practical as a good theory. So very briefly, what does this mean? It means whenever you're thinking about an intervention to fix a problem you have, you need to ask yourself the key question: are you trying to make failure less likely? Are you putting in barriers to care? Are you adding something new in? Or usual success more likely? Are you making it easier for people to see what's going on? Are you making it easier for them to do the paperwork? Are you making it easier for them to document stuff? Are you making it easier for them to understand what's happening for this patient? Are you making it easier for the patient to understand? Or are you just putting in barriers to prevent failure? Second thing is you need to learn from all events. Sometimes people talk about safety too as I'm just going to learn from what goes well. It's not learning from what goes wrong, not learning from what goes well, it's just learning from what goes. Okay? So it's paying attention not just to these unwanted outcomes, but also understanding about what's different about these situations and what is normal work and how do we make normal work more likely? How is it that these things happen that are so amazing? How is it that work happens? What are the variability that naturally exists in the system? And this actually involves us understanding what work is done is, what people are doing, what are the trade-offs they're making, how does work actually happen? For that one, I usually have quite a big, long example about it, but learning from all events is really, we now debrief a lot about our events that go well. We only pay attention, if you think about it, the last time you get involved in looking at paying attention to how work happens was usually in a root cause analysis as part of a serious and sentinel event. And we spend a lot of resources here looking at this stuff, and we have no idea about this stuff here. And the bit that I want to focus on today, because it applies, thank you so much, applies to building resilient systems. And this is about the idea again, is that it's about how do you build systems and teams that are able to monitor and adjust performance to achieve goals. And it's not just to threats, it's also to opportunities. How do you create this dynamic system that can see what's coming and respond to it, whether it's a good thing and we can grab that opportunity and go with it, or it's a risk that we need to address and keep an eye on. And it's about being prepared and being prepared to be unprepared. So even when the unexpected things happen, how can we see it coming and how can we respond to it? And it's not just in healthcare this is now starting to be talked about. This is in the military. We all have this idea that military hierarchy is you sit there and you follow orders and do all this sort of stuff. But actually, the modern military is now changing as well. And this is from General Stanley McChrystal, who was basically the Americans were getting their asses kicked in Iraq from all these insurgents who sort of arrive, blow things up and run away again. And they realised they had these very hierarchical structures that were set up that they couldn't deal with this sort of dynamic and uncertain situation. And they totally changed the way they did it. And his quote is, "In complex environments, resilience, this ability to adapt and respond quickly, often spells success, while even the most brilliantly engineered fixed solutions are often insufficient or counterproductive." Does that sound familiar? All right. So when we're thinking about deteriorating patients particularly, Eric Holnagel talks about this idea about, well, what are the things that give a system resilience? So resilience is not something a system has, it's just something a system does. It performs resiliently. It performs in a way that can absorb stuff and move on. And it's not just the idea of you rebound from an event and get back to it, or you react and get back. It's about the closest thing would be called anti-fragile, which is not only that you are better after, not just that you respond to stress and can cope with it, but actually that you're better after it. So the system can take what it does, can respond to it, can adjust to it, and can learn and get better afterwards. All right. So there's 4 things you need. The capacity to anticipate, knowing what to expect. knowing what to look for, to monitor your response, knowing what to do about it, and then learning is basically sense-making, knowing what has happened. So these are the 4 things you need for resilience in any system. These are the potentials or capacities that a system needs to have. And to me, this applies at a patient level right through to a system level. For a patient in ICU, where are we now? Where could we be going? What would it look like if this happened? What would we do about it? And then trying to work out what's happened here or what were the surprises we had. It can equally apply to a project you're working on. You know, we'll be finished in 2 months' time. Yeah, right. What would it look like if the project wasn't following on? What would we respond to it? And we've seen this with patients. What do you expect to happen? When will I get my outpatient appointments? What will I do if I don't get my outpatient appointment? These things apply throughout the system. The ability to be wrong and be safe and to learn from it, but the ability to adjust to dynamic conditions. Small pause. I've got 3 minutes, 2 minutes, 1 minute. Does that all make sense so far? Vague nodding. 2 minutes. I'm actually ahead. How exciting. All right. So we're going to move on now. And the rest of the afternoon is really about exploring these 4 potentials and what they look like for deteriorating patients. Okay, can everyone see that those things might be useful in a resilient system is essentially about identifying when things aren't following the plan and getting them back on track and being able to learn from it. Does that kind of sound like a deteriorating patient program? Okay, let's go through it and I'll prove it to you. So we're going to start with the thing that most people are familiar with, which is responding. The first program that was launched was the Rapid Response Teams, or what's the other name for it? Something in response. Recognition and response system. So respond, let's talk about respond. So we're going to have a case, and we'll run through a case and we'll use that to anchor some of the things that we want to talk about. Yeah. This is Mr. T. We're very grateful for him. This is a 72-year-old man with a history of heavy alcohol use, obviously. A smoker with COPD. He has atrial fibrillation and irregular heart and is on blood thinners, on dabigatran. And he has a history of recurrent falls. He lives alone but is quite malnourished, but he does have family and they come and visit him sometimes. They're around. 3 days ago, he had a fall. He was admitted with multiple rib fractures, those are the broken bits at the back. He had a CT head because they were worried he might have a bleed in the brain or something, and it showed no bleeding, but there was a bit of atrophy in there, his brain's a bit pickled. And because he'd been on the blood thinners, he wasn't able to have an epidural or a paravertebral block or anything like that, so he's been put on a patient-controlled pain pump, so a PCA. He was admitted for observation, and they were concerned that he was at high risk of alcohol withdrawal, which was fair enough. On day 3 days after admission, there is a rapid response call goes out to the surgical ward, where he is found on the floor. He is confused, he has a low blood pressure, he has falling oxygen levels, and he has a fever. And his resus chart says he wants everything done. Have you guys seen these cases? Yeah? Okay. All right, so how different is this to we often train our teams about cardiac arrest. We go to the sim lab and say, right, we're going to do a drill on ACLS. Have you all done your ACLS training? Apart from the doctors who never do because they're hopeless. So we go there and we go, there has been a cardiac arrest. The patient is on the floor in front of you. We will now go and do the cardiac arrest protocol. I will be the leader. I will be the scribe. I will be the airway person. I will be the other person, whatever. And we have our roles and we know what to do, and it's very clear what we should do. And we do drills. ACLS is often drills. We're going to do a drill. We have a set plan of what we want to do. And the focus on that is about efficiency. Can we do a drill? Can we get everything done? Does everyone know what's going on? And the analogy we hear is about a pit crew. Everyone forms up, we do this thing, we do it really quickly, and then we disband and we go off again. And that works really well when you have a known problem with a known solution and a known way forward. Right? I don't know if it works very well for this guy. I don't know what's going on with him. There's a whole host of things it might be. It's not clear to me what we should do based on his preferences and what the family thinks. I don't know whether he's got a problem that I can fix. There's a whole lot of uncertainty, and he's quite crook. So there's also urgency. And in this setting, it's not about efficiency, it's actually about the ability to adapt, the ability to find what's going on and to find a way through it. Do you agree with that? Yeah. Thank you for the people who nod, by the way. It's really, really cool. It's like a feedback loop. It's good. All right. So first workshop questions. who is the team? Who is on the team for this patient? I don't mean the rapid response team, I mean, who is this patient's team? I'm going to give you 10 minutes, so don't blow the surprise for me, it's just, I want to be left in anticipation. So who is the team for this patient? We often talk about that, if you talk to ward staff, they say, oh yeah, the Met team arrived, and it's like there's this kind of, it's like a Monty Python thing where the white chargers come down from the ivory tower, and they arrive and they go, I'm here! But I want to know, who is the team for this patient? Who do you need to involve in being the team for this patient? And once you've thought about that, is how do you train for adaptability in the setting of urgency and uncertainty? Great. All right, thank you. We're going to stop at there. I'm sure there's lots of good ideas, and the idea is to think about some of these things and to go back to your place. We're not going to be able to solve it all here now. Is that all right? We're just going to move on to the next bit. But I do want to talk a little bit about teams. So one of the things that come through with this, and we're trying to get across with the team stuff, is that the irreducible sort of unit, the quanta of healthcare now is teams. We don't work individually. We don't have heroic doctors who do their own thing. We work in teams, either us and the patient, or families and staff, or between different wards or different services, primary and secondary care, management and clinicians. We are members of many, many teams at different times, or even at the same time. Okay? And the idea is why we work in teams now is as things get more and more complex, you need more and more viewpoints brought to bear on a problem. We saw this guy, we've got social issues, we've got multiple organ problems going, you know, we don't know what the right thing to do is, we've got a resuscitation status, we've got lots of drug problems, pain problems, all these things. And the idea of this is that you need requisite variety, the ability to bring different viewpoints to match the complexity or the multiple problems of patients. So that's why we work in teams. And so we need to move away when we think about teams from a heroic model of I'm the team leader, everything to me and through me, and you just follow my instructions and let me know when you're done, to actually think about how do we build requisite variety in our teams? How do we bring those viewpoints to bear in a structured way to the complex problems that we have? And it changes the way you think about it. If you do a cardiac arrest, it's fine. You go, do this, do this, do this, do this, do this. This sort of problem is more about here's what we're trying to achieve, and we need everyone to be part of that. This changes how we need to think about communication from being about transmission. Did you understand what I said? Yes, I did understand what you said. To more about what have I missed? What do you see? What do you think about this? And that includes family viewpoints. What do you see? What's going on here? What doesn't make sense to you? So we need to turn this into what's called a social construction, the idea of that we all add to our understanding of the situation. And communication is about building that shared understanding. Now, communication with different teams is really tricky, and there's kind of a secret sauce for how you do it. And they've looked at this in quite a lot of detail in terms of whether you have a team, what are the key things that has to be present for a team to be able to contribute and be able to come around. Some of it's about goal orientation, some of it's about, mutual support, all those things that we're in this together, I'm doing it, we're doing this thing together, we'll try and help each other where we can. But this is a really key thing to understand, which is that Google looked at a lot of their teams and looked at the work of a woman called Amy Edmondson, and they were looking at what makes their teams really effective, and they were sort of thinking it was all to do with having really senior people, having the right skill mix of people, having all these sort of things. And what they found was the teams who performed the best, the teams who learnt quicker, who got more things done, were those that had high psychological safety. So those where the team had the shared belief that they could take risks. And what that means is not like I'm going to jump off a cliff. It means that I can say, I think you're missing something. This doesn't make sense to me. Are you sure about that? And so a lot of the stuff we need to do with our teams is thinking about how do we very quickly get together, form a team orientation. And if you don't have a shared understanding of what's going on and a shared goal, you don't have a team. And then very, very quickly forming the ability to have a psychologically safe environment, an environment where contribution is not just accepted, but actually expected. And that changes how we think about leadership too, which is more that leadership is now about setting the goals of what we're trying to achieve here. What are the problems we're trying to deal with here? And setting a climate where people can contribute and add their bit to it. Okay, and that means the ward, or it means the ward nursing staff, the family, the pharmacist, the drinking buddy, whoever it is. And it doesn't just apply in the teams that we have here, it actually applies, the same principles apply when we're thinking about the teams across the whole hospital. This idea of cross-boundary teaming, a team of teams. What are the relationships? How does the PAR team help out with this ward? What's going on in your reality? How do I do things that make sense to you? What's going on in ICU? How do we do these things? And how do we move from this idea of we work in silos to actually that we work in teams, and rather than breaking down the silos, we need to build the connections between the teams. It's a totally different approach. This is all very esoteric, so I'm going to be a little bit more practical. This is what we did. Doesn't make it right. I'm just trying to show you how it looks for us. So at Minimal Hospital, we had a interdisciplinary simulation group, which was the nurse educators, the medical education guys, and we had been doing simulation for 3 or 4 years. We started off in the simulation centre, we then moved into the ICU, and then we moved out into the ward with our PAR team, doing in-situ sims for patients. And we saw, we had a really good time. Everyone, we were debriefed. They went home a little bit miserable sometimes. We were trying really hard, and it was all going really well. And even when we moved in situ, which is now considered kind of the gold standard for some of these things, and we actually got really good at debriefing, and we were actually having really effective days, we weren't seeing any changes on the ward. We weren't seeing the changes in behaviour that we thought we would. We weren't seeing all the things that we wanted to happen, even though we were doing what would be considered pretty good. And what we realised was that we had spent a long time debriefing people about what they did wrong, and we talk a lot about leadership, and you should really speak up, all the usual things. And actually we weren't getting the behaviour change we wanted. And what we realised, we hadn't described what good teamwork looks like. So we came up with a framework in 15 minutes. And it's basically this. Does everyone know what's going on? Really simple question. And we then would integrate the tools. An S-bar sets the team in the right direction. A pre-brief says, here's what I think is going on, what the priorities are. And a recap keeps the team in the right and where we are going. Does everyone know what their roles are? Are we clear about the roles? Are we clear about who's leading? But are we also clear about the idea that people are part of this? You're not just passive followers, you are active. You are helping to deal with these goals and move us towards that. Are we clear in our communication? We did the whole closed loop, name person, all that sort of stuff. That's always in there. And the bit we added in here was, how do we ensure our goals even when things are changing? Anticipating, monitoring, responding, and learning. Okay, this is how it should go. This is how it might go. What will we do about it? What will we, and we'll spend time debriefing it. So we went from don't let the tube fall out to what will we do if the tube falls out? How would we know? What would we do? Who would we call? If we're doing an intubation, if the saturation's full and I can't get the tube and I will cut the neck, when will you cut the neck? What saturations? What's going on? We're being much more specific about the things we're looking for. What is it that we see coming? What are we worried about? But we also were describing how it should go. And this was designed to apply at a ward round. Okay, if things are going well, it's behaving like we think, by tomorrow we should be on this much vasopressor, moving towards extubation. That would be my expectation. Anything that's not that, we need to talk about. Actually, there's this I'm really worried about. If you start to see fever, it's going up, we need to go and get a scan. So we're talking a lot more about what's coming down the line, both how it should go and how it might go. Same thing with resus on the ward, same thing with deteriorating patients. How do we speak up? We had a nice little tool for speaking up. And how do we make it safe to speak up? So we spend a lot of time talking about reducing hierarchies, making sure that people understand that teams require the psychological safety. So talking about the fact that, this is a team. We are all here. We are you, and the leaders are situationally dependent on the people in the team to help them get the things they want done. We valued speaking up. Yes, it's a good idea. We're not going to do it right now, but thanks for bringing it to my attention. We really put that value in there because next time they might not. And we focused on learning rather than saying, why did you do that? I can't believe you did that. You're an idiot. Go away. Help me understand why that seemed the right thing at the time. What's going on? Be curious about what's going on. We rolled this out. We demonstrated it. And rather than using simulation to try and change behaviour, we used simulation to reveal the things we were trying to change. We did in-situ simulation with real teams, real scrubs, real names, real scenarios. For our PAR team, deteriorating patients things, we would do them in a toilet on the thing, we'd do them in the radiology. They would be specific to that service, and we would involve the services that we were working with as well. We would run through the framework, we would tell them what we were trying to teach, we would make it clear to them, and we'd debrief it as a whole team. The last thing we did was we reinforced and modelled it. We don't teach it and then go and say, off you go. We would get the SMOs in the unit who were involved in some program to model it the next day, to do exactly that. This is what's going on, this is my expectations, this is what's happening. We were modelling it. We weren't just hoping to change it. We were showing them and we were reinforcing it. Oh, I don't like that colour. I've got to. And this is the next step of simulation. It's really about how do you interweave it into the way that you work? How do you make your team culture not just something you do in a resus, but how do you do teaming in general? How do you form teams on the ward? How do you build the relationships between the resus team and the wards and things like that? What we found is over 2 years we didn't degenerate into chaos, even though we were focusing on adaptability. People liked to know what to expect and what was usual so they could tell when it wasn't usual. So people were using checklists more, but we were using them differently. People said, what are you expecting, what are you worried about for the SMOs? We saw an impression of the team felt there was improved team organising. They knew what should happen, and therefore they were able to anticipate what might go on. They were proactive about what's coming rather than just waiting for something bad to happen. And they described the fact that they could speak up, even though we saw that people weren't speaking up. They were doing something different. One of the things we hadn't expected was we didn't do the SMOs at the start, but after a while when we had this framework, people had an expectation of how it should go, and so they were asking the SMOs not involved in the program, what's your plan? What are you worried about? Can you just give us a quick recap about what's going on here? So we started to see that the followers were actually helping the leaders lead better. They were asking for what they needed to function. And this thing's really important, and particularly when we're thinking about korera mai and call for concern. We saw speaking up go away as an issue. We had said to people, speak up if you're worried, speak up if you see something. But what we found the problem was, if people didn't know what was going on, didn't know how it should go, and didn't know how it might go, and we hadn't created the space to say, if you see something else, let me know. We hadn't created that space for contribution. They were having to speak up. But once you let people know, when you say, if it's something different we need to talk about, you expect them to contribute. So speaking up goes away, and people say, that thing we talked about, it's not happening, or that thing you're worried about, it is happening. And if we think about it with the patients, we can't just be saying to them, if you're worried, speak up. They need to understand what's going on, how it should go, and how it might go. Absolutely vital. All right, we're going to move on. So that's the rapid response teams and a brief thing on teams. And we're going well for time. She's just quickly readjusting everything. Carry the one. So Mr. T, the previous day, into this day, he's been on an alcohol withdrawal scale. He had an SHO review. We're just going back, having a look at a few things about monitoring, about how do we detect when things are changing. So he was on an alcohol withdrawal scale. He was getting a bit febrile, he was a bit tachypneic, he was a bit confused, and he got some diazepam because he was on an alcohol withdrawal scale. He'd had a bit of a cough as well, but he's got COPD. And on day one when he arrived, his news had been adjusted because they thought he was very tachypneic while he was still sore and stuff, and it hadn't been changed since that time. So I want you to think about, and this is the question, this is called reverse engineering. I want you to think about how you would design a system perfectly so that a patient deterioration was never identified. How would that look for the staff? How would that look for the patient? Close the hospital. You can't close the hospital, there still has to be people in it. But you're right, some people say the way to make it safe is to not have patients. It works perfectly, it's great. So I want you to think about how would you design a system so that patient deterioration was never identified. It was very, very difficult to see when someone was deteriorating. So the idea with reverse engineering is you basically look at that and it all comes pretty easily, and then you say, well, how would we do the opposite of that? How do we build a culture where people don't have name, shame, blame? How do we make it so that people are approachable, that people know what's going on, that they're clear on who the patients are, what's going on, all these things. So does that sort of make sense how you do that? It's quite an interesting exercise about how it's so easy to see the flip side of it. But it makes it much clearer when you say to people, what do you think we need to make patients safe? That sort of everyone goes, when you say, tell me how it wouldn't happen, it's much easier. We have a bias in our heads to negativity. It's just the way we're wired. All right, we're moving on. Great. So the monitoring bit is really about, when you think about monitoring, it's really the gap between where we think we should be and where we are. So do our expectations and reality meet? And so the idea with the monitoring stuff is really about what tools are there to make the situation visible? I thought we'd be here by today, but we're not. I thought we would be better by now, but we're not. I had expected that we'd be going home, but we're not. So it's this mismatch between our expectations and the situation we find ourselves in. And that's kind of a bit about how we try and design some of the tools. So when you think about what an NZU is, at its best, it's a tool to help us understand where we are. At its worst, it's if you're over this score, you're sick, and if you're under this score, you're not sick. Okay? When you use it that way, it's not effective. But when you design it like this, it is effective because you can see a story in the chart. All right? So at best, it helps people understand where they are so they can detect the gap between where they thought they should be or what should be happening for this patient. And if you think about responding to deterioration, it's really about like things are going off beam and how do we get them back on as soon as possible. And we talked about it's not when they're dead, it's not when they're just about dead, it's trying to just constantly be adjusting to get this patient back on track and to identify issues early and get them sorted out. One word of caution, this is the new electronic system we have. So you'll note with this one, this is not the NZ user, I think Australian one, might be English. And you can see there's the colour bands which help you identify change. We're crossing things. So what they did with the electronic system is they've instead of the bands, they've coloured the boxes. It's very hard to see, unfortunately, sorry. They've coloured the boxes to correlate with what the bands are. But you don't see the same story. And if I've never seen that first chart, I have no idea what those colours mean. So when you're thinking about your tools, think about how do you set cues that tell a story, that tell you where you are. And it's not just about NZUs. That's only one way that we monitor. It's actually for the staff who say, I'm worried about this patient. Their score's not high, but we're not where we should be. There's something going on. And it's about them being able to monitor and see what's going on. Amber Care is a program where people say, I'm not sure which way things are going to go and we need to talk about it. So staff are saying there's uncertainty on here. And the Korero Mai and call for concern stuff can also be a source of monitoring. Hey, this is not going how you said it would. Something's up here. What's going on? I'm not happy with what's happening. But all these potential sources of monitoring only work. They only work if you have an idea of where things are going. If you have the ability to anticipate so that you can then detect the gap between where you thought you would be and where you are now. So this brings us to anticipate. All right, so Mrs. T's daughter arrived. She's looking very angry. She's upset and surprised that Mr. T had deteriorated. Nobody told me. She's concerned about him earlier. She sort of said he wasn't his normal self. And she said that he's been deteriorating for months and he would not wish for heroic treatments. All right. So 3 related questions. How would we enable staff to anticipate issues, what's coming for a patient? How do we enable patients' families to anticipate how things what's going to happen for a patient? And how do we understand the patient's wishes? How do we anticipate what they would want in a situation if things were to change? All right, go to it. So that's a workshop. You've got 10 minutes. All right, so anticipation is really about knowing what to expect, and it means knowing where you are now. So the ability to project ahead implies that you understand where you are and the direction of travel. And one of the things is that we realised after a while is that we're very good at saying, I'm worried this might happen, I'm worried this might happen. But when you describe where we are now and how I expect things to go, you don't have to describe every way that things might go wrong. By making it clear that this is my expectation, you'll go home, you should get an appointment within 2 weeks, you should be seen in the clinic within 6 weeks. So we're not saying if you don't get this, or for intensive care, we're saying, we don't have to describe every complication that might happen. We don't have to describe every which way a patient might go wrong. But we just have a shared understanding of what usual looks like for this patient. Does that make sense? And it's quite a different approach. And we're not very good at saying it. We're sort of saying, everything should be fine and we'll describe how it might go wrong. But actually we should be clear about saying what needs to happen for this patient to get home. What are we trying to achieve here? And I've been up to a ward call once where I got there and the patient had been in hospital for 18 months with an abdominal problem. And I said to the team, what's the next waypoint that we're working towards? And they said, it's an operation. I said, when will we know we're there? What does that look like? What things need to happen for that to occur? And they said, So no one had a shared understanding about where are we going, what's the direction of travel, are we on track or not? And so being very clear about knowing what should happen is a really key thing. The anticipation actually hinges on building a shared understanding amongst the staff, but also the patients and families about the current situation, what should happen, what might happen, the values and wishes of the patient, and what we'll do about it if things change. So actually a lot of our tools are really about, a lot of the stuff is actually communication, this idea about building this construct about do we understand where we are, we're in this together, what's your viewpoint, what are we trying to do here and what would it look like? And so a lot of our tools are actually communication, they're addressing communication. And I think this is the big bit here is if you don't know where you are and where you're going, then all the other tools are much less powerful. Okay, your ability to detect when you're not where you should be is much harder. Your ability to know when to speak up is much harder. So this is a really key thing. And this is the change in focus from a reactive safety system to an anticipatory safety system, which is saying, how do we get this patient better? How should that go? The last one is what separates resilient healthcare, resilience engineering stuff from things like high reliability, which essentially is not just that you can respond and do stuff and come back to a state, it's actually that you learn and you're getting better over time. And this really speaks to the kind of the relational nature of the work we do and about how do we make changes, small incremental changes over time that make the system better and better as we go along. So Mr. T, an update, he was changed to focus on comfort as per his wishes. He continued to deteriorate and died. His son-in-law got back from the Middle East and made a complaint about the failure to recognise deterioration earlier. It went to the HTC, and the HTC has come back, and I say this with my tongue in my cheek because I'm doing it right now, and they want you to write a new resus policy and a new resus form. Have any of you been in that situation? Are we going to write a new policy and it will fix it? Mark, you write them all the time, I've seen them, they're great. Anyone else? We often do this, we say the problem was there wasn't a clear policy or they weren't following it. Either we're going to beat them till they follow it or we're going to write a new one. When we fix the wrong thing for the wrong reason, the problem continues to happen. If we don't understand what's actually going on, if we react to what's in front of us rather than the drivers upstream of it, if we don't make sense of what's actually going on in our system, if we can't see the bigger things that are going on, we will try and fix the thing in front of us and it won't fix the problem. It will come back in a different way, slightly different patient, different time, but the same drivers are there. And if you think back to how would you make it so the system never picked up deterioration, it was things like staff not knowing what was going on. In theory, it's things like doing tasks, filling in paperwork without understanding what they mean. They're not tools, they're done for compliance. There's no communication within teams. They're busy, they're stretched, the wards are overloaded. So if you are only looking at what the patient and what's in front of you and you are not understanding the upstream drivers, you are not learning. So we need to try and understand what the real problems are that we're trying to fix. And it's costly and demoralising. Every time someone rolls out a new form that you fill in, you go, oh God, it's another form. So knowing what has happened. So one of the key things about Safety 2 is that it says there is no special cause for failure. And what you need to do instead is to say, and it means that things don't go wrong for a different reason than they go right. And we've talked about that. So this is now saying, well, actually, how do we make it more likely that this stuff happens, that people understand what's going on, that people can see what's happening? How do we make usual success more likely rather than put in barriers? And this means you have to take the time to understand work is done. You have to go to the front line. You cannot sit in your office and write a policy based on how you think your system works. You have to go to the front line. That includes talking to clinicians and it also includes talking to patients and families. You cannot assume you understand the experience of patients and families or of frontline staff. And the reason for that is that people do things that make sense to them. If you punish them for their behaviours, but they were doing something that made sense to them based on what they understood and what they were looking at, and you just punish that person, then someone else who is in that same situation is likely to make the same decision. And we have seen this there was a medication error with metoprolol, where a nurse didn't do the 5 rights, and it was a small dose, and they were in the press because they had made a medication error and they were previously a good nurse. And the bit that isn't reported is that 2 other people did the same thing, and there was another death. So when we don't ask the right questions and we don't say how come that seemed the right thing to do at the time, we miss out on the second part of that question, which is hidden, which is, and could someone else in the same situation do the same thing? Right. By understanding work is done and work is imagined, at the moment what we have is that we assume that work is imagined of the policies, procedures and guidelines is how things should be done, and the gap between that and the way things are done is a problem with what people are doing. Instead, what we need to work out is how do we bring rules more closely aligned to work is done so that they are followable? How do we make rules that fit with the way people work? How do we make rules that actually help people understand where they are and make their work easier? And this is from a guy from Intermountain, the Chief Quality Officer, who says, clinicians are the only ones who have the fundamental knowledge about the workflows. They're the only ones who understand the sharp end, the cold face. They don't control the systems that set the context in which they work. And the key question is, how do we make it easy for them to do it right? Okay, so your job as leaders or people leading a ward or leading a team is to think about how do I create the context that allows people to do good work? How do I give them the tools, the understanding, everything else to make their work successful? All right, the final workshop questions. So how are you going to go and find out about work is done? How do you understand the lived reality of other parts of your hospital? What other teams need from you in your service? And what they do, and the drivers and the stresses and the things they worry about. And how are you going to ensure that if you bring in a new policy, procedure, guideline, rule, whatever it might be, that it is fit for purpose, that it is followable and it makes people's lives easier? I think part of it's also understanding about what are the risks and hazards. And one of the things is when you look at lists from people that are done by experts is that people can write lists, but experts can tell you what's not on the list. So people who have experience and understand what's going on, they can see the bits that are missing, they can see the unintended consequences, they can understand what's going on. And if you have people in your organisation who understand not just their bit, but about how their bit fits with the rest of it, they're really good people to engage with about what does this mean, what are the flow-on effects, what are the unanticipated effects. And we've all seen those things where someone does a change and it has an unintended consequence somewhere else. And we're very often, these myths and rules evolve over time and places, and it's when you actually sit together and say, tell me about what you need from me to make this work, that actually it's quite different. We had that with our booking process, talking to the bookers, was quite a change. In terms of how you ensure new rules are followable, I think the last one about work is done is we had this with hand hygiene, where we used to, so our person would come around and go 65, 75, 60, 75, well done, 60, we'll try harder. And it wasn't until they came and they said two things. They said, I'm going to be humble, I need your help for this, and I'm curious. I'm going to sit in the bed space and watch. Can you tell me what you do and what has meaning? And when we did that, our rates are now over 85% for 2 years because we designed a process that's fit for purpose. So actually spending time being curious and understanding you don't have the answers and you need other people is a really big deal. All right, we're just going to wrap up now. Here it is, good. So this stuff is a fundamental change in perspective, and I hope you've got a taste of a little bit about how it feels. And it is a slight change, and once you start to see it, it's really hard to unsee it. It's one of those weird things. But just talking about what does an overall system look like, so really we're thinking about anticipate. We're starting to see about how does advanced care planning feed into goals of care and decision making. Building a shared understanding amongst the team, but also amongst the patients. Thinking about things like amber care and those sort of workarounds. Monitoring, thinking about NZUs, korera mai, but also thinking about how your staff can escalate. Responding, how you're going to design your teams to be adaptable, not just compliant, and doing drills. Thinking about things like PAR, outreach, all those other things, where it's about the relationships over time. It's not about just the intervention you do, and we are blessed by having a great PAR service who have built those relationships of support over time with the rest of the hospital, and are valued because of it. And the last bit is learning is about understanding work is done and focusing on how do I make usual success easier? How do I make it better and easier for patients to do good work? In summary, we work in a complex adaptive system, not a factory. People and teams are your key resource in creating safety. It's something we create every day, and you need to design your systems to make it easier for them. Singing and hand-holding. If those of you who want to get in touch with me, I'm always happy to talk. This is new. No one's quite sure what to do with it. It's a way of looking at the world. It's not a 180 degree. It's this. It's just a small turn to change the way you look at things. I hope you found it useful. It's the first time we've run this workshop, and my thanks to Fiona, to Jane and to Mark for helping facilitate it, and Emma on timing. Excellent job, although we ignored it. I hope it's been useful and interesting. We really value your feedback about what we can do to make the workshop different or better, but thank you very much indeed.